Major funding for Second Opinion is provided by the Blue Cross and Blue Shield Association, an association of independent, locally operated, and community-based Blue Cross and Blue Shield plans supporting solutions that make quality, affordable health care available to all Americans.
Welcome to Second Opinion, where each week you get to see firsthand how some of the country's leading healthcare professionals tackle health issues that are important to you. Now, each week, our studio guests are put on the spot with medical cases based on real-life experiences. By the end of our show, you're going to learn the outcome of this week's case, and you'll be better able to take charge of your own health care. I'm your host, Dr. Peter Salgo, and today our panel includes our Second Opinion primary care physician, Dr. Lisa Harris, from the University of Rochester Medical Center. Dr. Charlie Della Santina from Johns Hopkins, Karen Crotinger from Strong Hospital, and Dr. Gary Paige from the University of Rochester Medical Center. All right, it's time to get down to business. And our patient today is Patrick. He's 68 years old. He calls his doctor late one summer afternoon because he's feeling dizzy. His doctor asks him a few questions and discovers that Patrick has been doing yard work out in the hot sun. He says he thinks Patrick is dehydrated over the phone, tells him to drink plenty of fluids, and to call him the next day if he doesn't feel better. Sound okay to you?
That sounds about right. And I'd probably ask him if he had any beer before he was out there mowing the lawn or doing the yard work or any alcohol.
All right, so
contributed to that.
Patrick listens. Patrick does what he's told, but he doesn't feel better the next day. So he's in the doctor's office. He comes in. His doctor does an exam, finds that everything is, quote, normal, unquote, except for his blood pressure. It's too high. So he adjusts his blood pressure medicine, which he's been on for years.
So he said everything was normal. When we use those terms normal or WNL, that means we never looked. And we really need to do a more appropriate. I didn't really hear anything else in the history that,
no.
He says he's not feeling well or that he's dizzy. And that, to me, that's not enough information to try to figure out what's going on.
So really, you need a better history. Right. We have some dizziness experts here. What causes dizziness anyway?
Well, there are a variety of reasons. Medications are one, and one of the most famous is alcohol. Another would be a variety of systemic illnesses, even being nauseous. Food poisoning makes you lightheaded. Allergies can make you lightheaded, or the medicines that are used to treat them. And a variety of other medicines, particularly those which have an effect on the nervous system. And then there are diseases with specific elements that develop symptoms.
But do you like the word dizzy? Is that a fair word or one you like patients to use?
Well, I don't mind the word dizzy, but it doesn't tell me a lot. I'd rather people then narrow it down a bit. It tells me a lot more if someone says, well, I had vertigo. I felt like I was spinning around. Or I was lightheaded, like when I stand up too quickly. Or I feel like I just got off a boat and I've got constant disequilibrium. Or even, it's not that I'm dizzy, it's just that the world is swimming around in front of me when I move my head. If you tell me those things, I can get to a diagnosis.
How about I just changed my glasses? There's one.
Yeah, there's another.
Well, fortunately for us, we have Karen on the panel with us today. Unfortunately for her, she went to her doctor several years ago because you were feeling dizzy. Now, we have two nationally known dizziness experts right here. What I thought we ought to do is do a little game, if it's all right with you, sure, and see what a good dizziness workup interview would be like. So, Gary, Charlie, have at it. Feel free to jump in. Why don't you ask her some questions about what was going on with her? Who wants to start?
Well, I'll start, sure. Well, could you clarify just those four things I mentioned, without using the word dizziness for a moment? What was the symptom that you had?
The room was spinning, sometimes slow, sometimes fast. I could be sleeping at night, and all of a sudden I'd wake up because everything was spinning. I wasn't dizzy when I went to...
Did that start suddenly, or was that just something that gradually occurred?
It was very sudden for me. I didn't remember it coming on gradually.
So, oh, go ahead.
Are there circumstances in which this occurred and recurred?
For a while, it started fairly quickly, and it lasted a long time. Several years earlier, it had some some spinning, and that went away on its own. So I was trying to wait, but it kept recurring with more and more frequency. And I finally went to see a a physician.
Now, you're both asking very interesting questions. Is there a mental map you're using to try to steer through the potential causes, and what are you looking for with these questions?
Yeah, it's helpful once we know that you're talking about vertigo, the sense of either you spinning or the world is spinning around you. Then really the next thing I need to know is about the timing. If you have episodes, specifically if you had more than one episode, then I need to know how long an episode of spinning was, ignoring all of the feeling lousy and nausea afterward. Just if you had a stopwatch and you started it the moment you felt like you were turning, and you stopped it the moment that stopped. How long is that?
It would, if it started at night or woke me up and I would get up, it would last an hour or two. Once I was up and upright, I would try not to move my head as much and try to get through the day so that I could leave for work. It eventually got to the point where I couldn't drive.
So you would wake up in the middle of the night and you would feel that you were constantly spinning for an hour or two. It's not a bunch of separate little episodes provoked by movement.
If it stopped and I leaned over, it would start, but mostly it was would start during the night and stop during the day and then start up.
So you mentioned vertigo. Vertigo is one of the things you're ruling in or out. What about presyncope, disequilibrium, lightheadedness? All of these things you're trying to get a handle on. These questions are designed to sort of parse that out.
Right, that's right. So presyncope is a fancier way of saying lightheadedness. It's that feeling that you'd get right before you pass out, and syncope is passing out. Presyncope is that feeling right before it happens.
Okay.
Disequilibrium is a fancier way of saying I feel off balance, like I got off a boat.
And the problem is sometimes people who get vertigo also get these, they call them dysautonomic symptoms, and that leads to lightheadedness and can actually cause fainting.
So do you know enough about Karen's problem now to venture a tentative diagnosis?
Not done yet. Is there something that you do physically, bend over, look up, roll over in bed, that would provoke the onset of these symptoms?
I would say yes, because if I woke up without the dizziness one morning and get in a shower, if I would look up, it might start. If I wasn't dizzy and I'd lean forward to pick something up off the floor, I'd get dizzy.
Or come back up from leaning over?
Back up. And sometimes it was really bad. I would literally, on the way into work, hold onto a wall to walk into the office. Heaven forbid I should stay home, but it was...
And you hadn't been ill prior to this? You didn't have a cold or some type of upper respiratory infection prior to the onset?
Nope.
Now, if having provoked such an episode, if you were just in a situation where you could actually stay perfectly still, would it go away more quickly?
It would.
So if you were in the shower and you did that and you just put your head back and just stayed put, would it just go away?
Right.
How long would it take?
I would say it took an hour or two, depending on...
Not standing in the shower for an hour.
Oh, no. But staying upright and not moving or moving fast. So I wouldn't turn. I would literally try to almost be robotic and just move through that morning without moving so that I could...
But those actions themselves are moving. So if you were perfectly still, suppose you... Well, did it ever happen rolling over in bed?
Yes.
If you did that and you rolled back and just stay put, lie down, you're not moving at all, not walking, would it quiet down more quickly?
About 20 minutes.
20 minutes.
I'd say about 20 minutes.
So you were spinning for 20 minutes? Not just motion sick?
No, it was spinning.
How are we doing on a diagnosis here?
Sometimes faster
We
than
close?
others.
Well, you can tell from the questions he's asking. There are a couple of really classic scenarios based on timing and based on, say, changes in your head position or orientation with respect to gravity. Classic one is you have vertigo that starts when you roll over in bed. But you need to flesh out the rest of the history. For one thing, one of the causes of vertigo that's in my mind now based on her story, it's so common that people are entitled to have more than one diagnosis. And so we need to ask a little bit further about other things that might be going on.
And one of the things, certainly, you know, for primary care, we really like to observe a patient. So did they walk into the office under their own power? Were they falling over to one side or another as they entered the exam room? Were they able to get on the exam table by themselves? And what are her eyes and her body movements like while I'm talking to her? All of that gives information.
Is it fair to say that given what we've heard, vertigo is pretty likely? And what is BPPV anyway? You smile. Someone must have told you that's what you've got.
I translate that into old age.
Well, so BPPV, it's sort of an unfortunate name. It's benign because it's really not that big a deal. Paroxysmal is a way of saying that it comes in episodes. Positional, vertigo. So this is a syndrome kind of like what you described, where typically, classically, you get it when you lay down in bed and you roll to one side. Or if you look up, anything that makes your nose point up toward the sky and you lean over a little bit. And the mechanism by which this causes vertigo, really to understand it, you need to understand how the inner ear works.
If you look to your right, there's a jugunda inner ear.
And hence
We secreted this inner ear just there.
This
just
happens to be Paul Bunyan's ear. And what you can see here is the outer ear. Sound enters the outer ear. We're all familiar with the sense of hearing. Very few people growing up have ever heard of the vestibular system, which is what we're really talking about, the sensory system responsible for these peculiar symptoms. Most people don't know about it until they get into trouble, like Karen here. This happens to be the business end or the end organ. So what we have here is the more famous cochlea, which is the hearing end organ. Sound, and what we have here are a set of mechanical devices. There are two classes of mechanical devices. These little tubular devices are called the semicircular canals, and they measure head rotations. Head rotations are movements like this or like this or like that. And you can see that there are three, and they're sort of like all perpendicular to each other, like the corner of a box. It's a three-dimensional device, given all three of these circles. And then there are two that are buried inside called the otolith organs, which are basically pancake-like flat membranes with a calcium-containing structure on top of them, which makes them bone-like, stiff and heavy. And what they do is measure linear accelerations, the most famous form of which is gravity. So they're basically gravity sensors. But
so, if I may, they tell you which way's down.
They tell you which way's down.
And
they also
this
tell
tells
you
which ways you're tilted.
Turning.
Right, you're turning.
Turning.
Right.
They give you a instantaneous readout, like a speedometer of the car, of angular velocity of the head in 3 dimensions.
That's pretty cool, actually.
Very cool.
Right. So you don't normally think about this because it's working, but it's working in the background to keep your eyes on target. For instance, every time you turn your head to the left, your inner ears are measuring that head movement, sending a signal to the muscles around your eyes, telling them to pull in just the opposite direction at just the right speed to keep your eyes on target. If that didn't work, the world would look like you're watching it through a handheld video camera.
Just jittering all over the place.
Right, exactly. Every time you move your head. This is such a reliable reflex that you follow it even when the information coming from your inner ear is abnormal. And so you can imagine that those otolith end organs Dr. Paige was talking about, they're actually a bunch of crystals embedded in jello sitting on top of a shag carpet. And the hairs of that shag carpet are little sensory cell structures, and when they get stretched one way or the other, you get a sense that you're tilting. But if some of those crystals break free and go floating around, they can end up in one of the hula hoops there, the semicircular canals. They float down to the bottom, and they sit there not causing you any trouble until you lie down in bed and turn your head to the side.
Imagine a container of orange juice, which with pulp in it tends to sink to the bottom. If you happen to turn the pulp, the orange juice container over, the pulp now accelerates and then sinks to the other side and collects. That's precisely what happens inside one of the semicircular canals that has this garbage collected. If you turn over, roll over in bed, the gunk that used to be at the bottom is now at the top. Now sinks to the bottom, and while it's doing that, you get a thrill of your life.
Now, Patrick, things have gone from bad to worse for Patrick. It's late at night, 2 days after that visit with the doctor. His wife is driving him to the emergency room because he's been vomiting straight through for the past 20 hours. Now what? What do we do?
Well, certainly we have to stabilize his acute condition, which means if he's vomiting for 20 hours, he's dehydrated, and we have to replace those fluids and try to calm some of the nausea and vomiting secondary effects.
Want to know what he's complaining of, other than vomiting?
Yeah, that was just going to say, we need to know about other systems.
He's complaining of incessant spinning. It will not stop. And tinnitus. He's got a ringing in his ears. He's also got a headache in the back, and he's got a neck ache. Now what?
Yeah, well, that's a concern. This is a guy you'd want to examine, particularly if he calls in and says that this is a headache unlike any I've ever had before.
That's right.
What worries you about that complaint?
Well, that's a classic complaint. If someone says, I've never had a headache like this in my whole life, I take that headache much more seriously than one that you've had 100 times before.
You're worrying about an aneurysm, a leaking aneurysm, which can be a life-threatening.
Well, on exam, it does not say here that his neck is stiff, by the way.
You're worrying about meningitis or brain infection.
But, well, I can tell you that one of the things that is noticed in the emergency room is that Patrick has something called nystagmus. What the heck is nystagmus?
Nystagmus is a to and fro movement of the eyes, usually both eyes, and it's usually, in a situation like this, most likely going to be a slow component with the eyes then resetting itself and continue to move more or less like my fingers are right now.
Now, you actually induced nystagmus in one of our volunteer staff members. Just explain what was going on.
Well, I spun her up on a chair, much the way you would do if you were playing pin a tail on the donkey and spinning somebody up, and then stopped her suddenly. And when doing that, the semicircular canals were generating a signal about head rotation to her, and her eyes were responding to compensate for it. And you can see they're moving slowly to the right and then beating to the left. And actually, I asked her, what direction do you think you're moving? And she said, well, I'm rotating to the left, and then slowing down. And you can see that the eye movements are slowing down as well. About this time, she said, I'm stopped. And indeed, her eye movements had ceased.
I got to tell you, right now, she's lying flat on the floor and is complaining of a headache. So that's one of the things he's got. He's also complaining that he's off balance. He has a sense of constant movement. His world is just not still. They did get a set of vital signs. Vital signs are normal. He has no fever, no perceptible hearing loss. They examined him, his tympanic membranes, the inside of his ear that you can see, and the tonsillar pillars inside his mouth. They are slightly injected, meaning they're a little bit red. Lungs, heart, neurologic exam was normal. His blood test, they did a CBC, Lisa. Chemistry profile, normal. And his head CT, which they did, was normal. I guess they did that at least in part because they were worried, as you were, that he might have been having a bleed inside his head. What's wrong with Patrick?
How about another couple of questions from the emergency room?
I'll answer them if I've got them in the chart, but that may be all we can get.
You'd want to know whether there's some evidence at all of some kind of pending, budding, or previous viral illness? Or
Not that he gave a history of.
Not that he gave a history of.
Right, and they tell you that he's afebrile and his white count was normal.
And he has had high blood pressure. We learned that before.
That's right.
And he's taking medications for it. So you want to know a little bit more. Did he ever have a heart attack, angina? Did he ever have a, call it transient ischemic attacks, of neurologic dysfunction?
Not my history
ever.
here.
Okay.
Now, why are you asking about a virus?
Because, well, the virus. So there is a syndrome called vestibular neuronitis, which is a viral, post-viral inflammatory process of the inner ear, which can generate nystagmus and actually injures the vestibular end organs, nerves.
Well, I'll tell you what the emergency room physicians thought he had. Vestibular neuronitis. And so I guess they agree with you.
Well, no, I didn't say I thought that was it. There's another element which I was just getting to, and that's cardiovascular. He's 68 years old, and he's on blood pressure medications, and his blood pressure was high after the first whatever, it was high somewhere. So there's a way that the cardiovascular system can masquerade as vestibular neuronitis in that age group, and that is a ischemic, that is not enough oxygen to the system for a moment in time to generate such a glitch.
So what you've described is a guy who suddenly lost function in one labyrinth, one inner ear. And neuronitis is one thing that can do it. It's probably the more common one. But maybe at least as common is a loss of blood flow. And then there are rare and potentially deadly things that we need to look for that look a lot like vestibular neuritis.
The vestibular labyrinth, that is, this guy, is way at the end of the arterial line. It's a little bit susceptible anyway, and it operates with an enormous metabolic load. So the reason this system works as exquisitely as it does is because the nerve, which is this white thing coming out of both the cochlea and the vestibular apparatus, is carrying constant barrage of information to the central nervous system. In the vestibular system, the average neuron, which is the cell generating the information to the brain, is firing at around 90 impulses per second, which is enormous. And there's a couple of million of these coming in from both sides. Now, if you just as much as squeeze a little less blood out of this thing, it's easy to see how that can disturb that a bit and maybe bump off 5% of the cells, 2% of the cells, and it will show up exactly like this.
If you look on an MRI, you'll see these little white spots, and we interpret those as tiny capillaries that have closed off over time. We don't worry about it because they're asymptomatic, and your brain is so powerful it works around them.
But he's got symptoms.
But if you had one of those little spots, one of those little capillaries, block off in your ear, you can't rewire around that. You're losing that part of the ear. And when you have that sudden imbalance of input between your two ears, you're going to have this acute vestibular syndrome and all of these symptoms.
Well, this is a lot of technical talk here. All right, so let's pause just for a minute and sum up some of what we've been talking about. Dizziness is a vague word. It can mean different things to different people, and you would be amazed how much a good history can tell your doctor. So, a good interview needs to be done by your doctor to find the root of the problem. Be prepared to be grilled by your doctor if your doctor is doing it right. All right, remember we're talking about Patrick, diagnosed with vestibular neuronitis. Also on our panel, Karen, glad that you're here, who was diagnosed with benign paroxysmal positional vertigo. All right, you were worried about it. You finally saw your doctor. When you finally got there, got the diagnosis, how did your doctor treat you?
When I went in, it was the day I woke up to go and see the practice, there was no dizziness. So I was under the impression I'd be sent home and would have to come another day. But they did the tests. I wore the heavy glasses that was in the video. And
they spun you?
They didn't spin me. They put balloons in my ears, fluid, I believe, in the balloons, recreated the dizziness that I had, and I was extremely dizzy within an hour or less from having the tests. The results were this inner ear, I call it sediment, but they gave me an exercise to do. And we did the exercise in the office, and within a very short period of time, everything was gone.
So basically, you're repositioning this the sediment or the orange juice pulp, if you will.
What you're doing is getting it from the place where you want it not to be. You're basically rolling it around so it resettles, rolling it around, and then sitting up, and so it goes out of the semicircular canal into this thing we call the vestibule, this basket down here, so it can be, in a sense, eaten up in its own time.
And shocking. It works.
Fast.
How fast?
Within the hour.
Really?
I would say under an hour.
Caveat with all of that, it's important that, yes, you had benign paroxysmal positional vertigo. Some of us shorten that, take out one of the P's. But if you go back to Patrick, who has a little bit of a different story, because he's older and he has hypertension, and he has to be aware that his dizziness or recurrence of symptoms may be something else.
Right. So the motto here, and we're going to go right back to Patrick now, is kids, don't try this at home.
Right.
Well, you need to know which end organ is the one. You just can't do an exercise and expect it to work.
Well, Patrick didn't have what you had. He had vestibular neuronitis, and that's caused, in all likelihood, by a viral infection. So now, how do you treat someone like Patrick? Not exercise, not...
Well, we haven't confirmed that that's the case. It had the trappings of that, but as...
Well, his doctors were pretty convinced. So for the sake of argument, let's say he's got it. How would you treat him?
Well, if we're going to agree that he's got what we call vestibular neuritis, which I call it an acute vestibular syndrome, then I'm going to treat him initially with just some things to make him feel better in the short term.
And what would that be?
Well, he's going to be nauseated. He's probably been vomiting. We might give him some fluids, as suggested earlier. We might give him something that amounts to a sedative for a few days to get him over the acute vertigo. In addition to trying to just make him feel better immediately, we have excellent evidence from a study in 2004, the New England Journal of Medicine, one of the best studies I've got available to steer my pharmacologic care in these patients, tells us that if we treat them with steroids, prednisone is one, then they have a clearly better chance of recovering function when they're remeasured 3 months out. So we treat them with prednisone or a similar drug for about 3 weeks. We might give them a medicine to keep them from getting an ulcer during that time.
All right. I'll tell you, they gave him prednisone, meclizine, diazepam, which is a sedative-like drug. Are these all the kinds of drugs that you think are appropriate for him?
Yeah, but there's an important caveat here, is that meclizine and the diazepam, those are Band-Aids that we use only for a brief period, maybe a few days. After that, the last thing you want is to be sedating yourself out of having symptoms, because it's those symptoms that are going to impel your brain to adapt and fix the problem in the long term.
Well, Patrick comes back to see his primary care physician. It doesn't say here, you know, exactly what his symptoms are minute by minute, but he does come back to his primary care physician 2 days later. He's still symptomatic, spending a lot of time in bed, and after 4 days, he reports, eventually, he's getting better. Finally, after 7 weeks, he reports he is better, and he has no residual symptoms at all. Now, 7 weeks is an awfully long course, it seems to me, to be this disabled. Is this a typical course for this disease?
Well, most people are going to get better within about 3 weeks. Someone who takes that long typically is either older, usually older than about 70, or taking some sort of sedative, including alcohol. Or they have a different problem. And an important thing in a guy like this is to know that that acute hit to the inner ear can release some of those crystals that go floating around and secondarily cause a bout of BPPV.
Let me add a tidbit to this. So we haven't talked about the intensity of the initial pathologic event. There's viral neuronitis that takes out a few percent of the end organ, and there's 50% or 80%. They have direct ramifications as to the intensity of the current symptoms and how long it will take to recover from them.
All right, we're going to pause again. Boy, there's a lot of information about something that sounds as simple as plain ordinary dizziness, isn't it?
Yes.
A lot of stuff there. While dizziness is very common, even though there are many effective treatments, often many people just suffer with it in silence. Now, it's important to work with your doctor to get a diagnosis so then you can get the treatment that works. Now, before we go, Karen, how are you doing?
Great. Have no problems whatsoever since
I'm delighted here, too.
Well, we are out of time, but you can continue this conversation on our website, secondopinion-tv.org, where you'll find transcripts, videos, more about dizziness, other healthcare topics. I want to thank you for watching, and I want to thank all of you for being here. I'm Dr. Peter Salgo, and I'll see you next time for another Second Opinion.
Major funding for Second Opinion is provided by the Blue Cross and Blue Shield Association, an association of independent, locally operated, and community-based Blue Cross and Blue Shield plans supporting solutions that make quality, affordable health care available to all Americans.
Second Opinion is produced in association with the University of Rochester Medical Center, Rochester, New York.